really not a black, it's really not a black and white document where if something is on the Beers list, you can't use it. And if something is not on the Beers list, go ahead and use it at any situation. It's really a tool to evaluate patient's med list on a very individualized basis. So in today's healthcare environment, we're all talking about patient-centered care, and we've got the 4M framework that everyone is trying to achieve. And one of the pillars is medications. And when you look at that pillar very specifically, what that pillar is designed for is to screen for those high-risk meds that a lot of which are on the Beers criteria. So that's how the patient-centered care and the Beers list are connected in some way. And I would argue that any medication can be high risk if used in the wrong patient. Medications really impact every one of these pillars in different ways. But today we're just going to focus on the Beers criteria. So initially the Beers list came out in the late 1980s, early 1990s. And at the time, it was really supposed to be used in nursing homes only. In late 1980s, there was an uproar nationally about the poor management of patients in skilled nursing facilities. There were hidden cameras brought in and showed patients slumped over in wheelchairs, passed out in beds from over medication, and these meds were really psychotropics were really used to sedate the patients and to chemically restrain them. So after that was sort of revealed, Dr. Mark Beers, who I think practiced at UCLA, developed this short list of meds not to use in nursing homes inappropriately. But over the years, I think people have looked at this criteria and decided that really it can be applied in any healthcare settings. So now it's used in SNFs as well, but also in AmCare settings, like at UCI Department of Geriatrics, we use this criteria pretty frequently. It's also used in hospitals to track high-risk medication usage and inappropriate adverse events related to that. So it's used in any healthcare settings. And it's really, again, it's the Beers list is there to improve your medication selection, to reduce potentially inappropriate medications, which is what PIM stands for. And really, I think the Beers criteria panel recognizes that prescribing is a very individual thing that we do, and it's very patient specific, and there's always a risk versus benefit analysis that goes into every selection of medications. So some of these meds on the Beers criteria we use all the time. But when we use them, we know why they're there and monitor for those adverse outcomes that they can lead to sometimes. And as long as that's in place, we can use these medications effectively in our patients. Next slide. So this is this first table is the bread and butter of the Beers list. It's always been part of it, and it's the table of anticholinergic meds. And this, in the 2022 update, they've seriously shrunk this table because there were a lot of medications on it in prior iterations that were just not used very often, very old meds. But if you look at this more carefully, you see that there's a section of antidepressants. They're all tricyclic antidepressants, and we know that all tricyclic antidepressants have anticholinergic profile, amitriptyline probably being the worst one. But then you've got things like paroxetine on there, which is an SSRI, but it has a little bit of an anticholinergic effect. So you probably don't want to use this in somebody who has some kind of cognitive impairment, because the reason this table is so important is because anticholinergic medications obviously have side effects like dry mouth, constipation, urinary retention, tachycardia, but also they can increase the risk of dizziness and cognitive slippage. And that's what we're trying to avoid in our older adults. So paroxetine has a little bit of that. So if somebody is complaining of memory problems or family's noticing something, that's probably not the first SSRI you want to use in that patient. For doxepin, it says, you don't want to use doxepin at greater than 6 milligrams. There is a low dose doxepin formulation that's just used for sleep. And at the doses of less than 6 milligrams, it's not supposed to cause a lot of anticholinergic side effects. In our clinic, we're super conservative, so we really don't use that either in our patients with cognitive slippage. You've got all the urinary antispasmodics listed here. Obviously, oxybutynin being probably the worst one in terms of anticholinergic profile, but some of the better tolerated ones, things like trospium, for example, can also be a problem in patients with cognitive impairment. Promethazine is on this list, and technically, I guess promethazine is listed as an antihistamine in all your drug handbooks, but it is a relative of a phenothiazine, so an old style antipsychotic kind of drug, so it can cause significant anticholinergic profile. So you want to be careful with that when you're prescribing Phenergan for, cough related to COVID or whatever. These antihistamines on this list, a lot of these are over the counter. So the trouble with this is most of your patients won't tell you what over the counter meds they're taking. And generally speaking, physicians don't ask at regular appointments because they don't have time to go over all of that. So it's quite possible that your older adults are buying this by themselves without letting you know. And that may be why they're having things like memory problems, confusion, because diphenhydramine is probably the worst one, but some of these other ones like brompheniramine, chlorpheniramine can certainly contribute as well. Some of these are still prescription, so things like hydroxyzine is still a prescription antihistamine. Sometimes it's used for anxiety, I think inappropriately because it can cause confusion in older adults. Meclizine sometimes we use as well. So just be careful with those because they can cause some of those nasty anticholinergic problems. The antipsychotics here, they're primarily all older antipsychotics that we generally don't use, but one is olanzapine, which is an atypical one. And olanzapine is still pretty low in extrapyramidal profile, so that's why we sometimes end up using it. But the flip side of it is highly anticholinergic and highly orthostatic, so it can really contribute to dizziness and that anticholinergic profile. And then you've got these GI antispasmodics that we often use for irritable bowel with a predominant symptom of diarrhea. Again, be careful with those due to its anticholinergic profile. And some of these, so scopolamine, it excludes obviously topical things that you would use in the eye, but scopolamine comes as a patch that we use for motion sickness. So be careful with patients going on a trip and getting confused while there. And also in combination products like Lamodal, for example, it's got atropine in it. So when you're treating diarrhea, keep that in mind. Some muscle relaxants, cyclobenzaprine for one is related to a tricyclic structurally. So it too has anticholinergic profile. The other thing they want you to really focus on in this 2022 update is this concept of anticholinergic load. So if one anticholinergic is bad, multiple anticholinergic meds can contribute further to this cognition issue and increase fall risk and all the other anticholinergic types of things. So you really want to keep that list of anticholinergic meds to a minimum. And if possible, don't use any of them. And here's a reference for this data. Next slide. Okay. Let me get rid of this. Oh, shoot. I just screwed up my view. Now I can't see it. Okay. I'm having trouble seeing the slides. Can I share my slides? They're all of a sudden they got really small for some reason. Oh no, here we go. Got it. Sorry. technical difficulties. Okay, so this is a table that talks about representative drugs that are potentially inappropriate. So the stuff in yellow is the 2022 update. So for the 2022 update, you've got they're really making a strong effort to call your attention to not using benzodiazepines. So because obviously they increase the risk of sedation, cognitive impairment, fall, and fracture risk. But if you look at this section, muscle relaxants are here, benzos are here, all the Z drugs, they can also cause the same risk. So you really have to be careful with all of them. For antipsychotics, there's also a 2022 update with very strong language about using these drugs as a last resort in patients who are demented and have agitation, and I'll have a slide on that. With proton pump inhibitors, there's a clarification and just sort of a focus on really not wanting to use it long-term, more than 8 weeks. Why do we not want to use PPIs more than 8 weeks? Because with long-term use, you're putting the patient at risk for C. diff infections, other infections like pneumonia, potentially GI malignancies, some vitamin deficiencies like B12 deficiency, magnesium absorption goes down, calcium absorption goes down, so they're really at risk for fractures. And the evidence for this is limited, but it's there. And so in clinical practice, I will often find somebody on long-term PPI with a pretty low magnesium level or a low B12 level, which could be a problem, especially for those patients who are cognitively impaired. Sulfonylureas have the list for potentially inappropriate sulfonylureas has been fully expanded to include all of them. So prior to the 2022 update, only the longer acting sulfonylureas were on the list, so glimepiride and glyburide. But with the 22 update, glipizide also made the list. Again, it's there because there's an increased risk for hypoglycemia. So it doesn't mean that you can't use them, but you should be very cautious about using them, especially in patients whose blood sugar fluctuates, to limit that risk. SGLT2, so things like Jardiance and Vocana are added to the list because they're new drugs and we have more information on their use in older adults. So they should be used with caution because there is a risk for infection, increased risk for UTIs and mycotic infections in older adults. And we do see that pretty routinely when we start things like Jardiance. You have to be careful with a slow titration and really monitoring for symptoms. And there's also an increased risk for ketoacidosis. And desmopressin, there's an update for 2022. It does have the risk of hyponatremia and there's safer alternatives available. But if you're not, so these are just the updates. If you're not familiar with the Beers list in general, I would look at this other stuff like nitrofurantoin is still on the list. You really don't want to use it with creatinine clearance of less than 30 for, in a prophylactic situation. It does increase the risk of pulmonary toxicity. All the NSAIDs are on this list for obviously increased GI bleeding, peptic ulcer risk, but also renal insufficiency. So, and some NSAIDs are particularly nasty, like Toradol, for example, and indomethacin. They're still selectively isolated as really drugs to avoid, but NSAIDs as a general class have this risk. You want to stay away from sliding scale insulin when it's used by itself. So I think sliding scale insulin is always problematic in older adults because it's very difficult to follow instructions and it's really easy to draw up the wrong amount and cause a hypoglycemic reaction. But the Beers list specifically says you should not use the sliding scale insulin by itself without a basal insulin being on board. Magestrol, really not very effective for weight gain in older adults and does have significant thrombotic risk. So we generally don't use it for that. Centrally acting agonists and things like clonidine, for example, is centrally acting and it can cause significant bradycardia, orthostatic hypotension, and sometimes confusion in older adults. And alpha blockers are known for their orthostatic hypotension, so you have to be very careful with that. Things like desiccated thyroid is just not a very reliable formulation. So we try to stay away from it because it leads to fluctuating thyroid function tests. And things like testosterone really should not be used in everybody with low mood or low energy. It's really reserved for patients who have confirmed hypogonadism due to inherent risk of testosterone use, like cancer and cardiac issues and cholesterol issues and things like that. Next slide. So this is the update for benzos. So there's nothing new about this, except now it's part of the Beers criteria. So they want us to remember that benzodiazepines put patients at risk for potential abuse, misuse, and addiction. Concomitant use with opioids results in profound respiratory depression and sometimes can lead to death. And that's why you really want to provide that naloxone for anyone with that combination or just on opioids alone, really. And there are also things that benzodiazepines do to older adults that generally they don't do to a younger population. They're much more sensitive to benzodiazepine side effects, like confusion, mental status changes, delirium, certainly increase the risk for falling. And then you have this whole amnestic syndrome that can happen with benzodiazepines where people, get out of bed, make dinner, have no recollection of it, get up in the morning, get into a car, drive, kill a pedestrian, and have no recollection of that either. So for that reason, they're just not safe medications to use in older patients. And here's a reference for that. Next slide. So for the antipsychotics, again, none of this information is really new, but they just want you to focus on it, that when you use antipsychotics for agitation in your demented patients, it's really an off-label indication. Antipsychotics are only FDA approved for schizophrenia, bipolar disease, Parkinson's psychosis, and adjunctive treatment for major depressive disorder, and short-term use as antiemetics, but not agitation in older adults. And so if you are using them for those behaviors have to be clearly identified as being a problem for the patient, a danger to a patient, or a danger to the caregiver. And by identifying those behaviors, you're also allowing whoever is administering the medications to monitor for efficacy, because sometimes we use these antipsychotics without any effect. The behavior still remains. So by identifying the behavior, you're giving the caregivers more monitoring flexibility. And so you can tell whether this behavior goes away when these drugs are given. And really, these drugs should be given as a last resort after having tried non-pharmacologic interventions like redirection, reassurance, things like that. Sometimes an antidepressant can be helpful. Sometimes some other non-pharmacologic approaches may work. So these drugs should be used for agitation only as a last resort at the lowest effective dose, and periodic reassessments and dose reductions should be done. I saw a couple of clinical pharmacists on this meeting, and we've known about these restrictions for decades, really. So this is just, clarifying it for the prescribers as well. Next slide. Warfarin has been added to the 2022 update. It is no longer considered drug of choice as initial therapy for venous thromboembolic events or non-valvular AFib, unless the newer anticoagulants are contraindicated or there are barriers to use due to cost, for example. Warfarin generally is associated with a higher risk of bleeding, so that's why it's not recommended. But if you have stable patients on Coumadin who are taking their meds regularly, getting their INRs checked regularly, and have no issues with bruising or bleeding or drug interactions, it is okay to continue. So that's where the flexibility in some of these recommendations come in. Next slide. So here's another table that looks at inappropriate medications when they're used in combination with particular diseases or syndromes. So some of these are a little bit problematic, and I'll go over that in a second. So if there's a history of falls or syncopal episodes, you really want to be careful with all of these anticonvulsants like gabapentin, pregabalin, antipsychotics, the benzodiazepines, the Z drugs, tricyclic antidepressants, SSRIs, SNRIs, mirtazapine, cholinesterase inhibitors, and alpha blockers. So this is a pretty extensive list, right? Obviously, we don't want to use benzos or the Z drugs when there's a fall history or syncopal episodes. That's a pretty straightforward recommendation. And alpha blockers probably aren't the best choice for hypertension with that history. That's clear. But we do use a lot of SSRIs. We use a lot of SNRIs. We use mirtazapine, and we certainly use cholinesterase inhibitors in our demented patients. So how do we reconcile this recommendation with these drugs? I think the key here is that you know that the risk is there, and you start with a lower dose, titrating slowly and monitoring the patient carefully. So this is one of the reasons when we start an antidepressant, we start at a tiny dose to make sure the patient tolerates it, and then wait at least 2 weeks to sometimes a month to make a change in dose, and watching for that side effect. That's one of the reasons when we're starting donepezil, for example, we're only going to start with 5 milligrams, keep it on for a month, have the patient come back, reassess, see how it's working, and then go up to 10 only if the patient can tolerate it. So it's not that you can't use these medications, you just have to use them carefully, recognizing that they do increase fall history, and some of them will increase syncopal episodes. For delirium and cognitive impairment, these are all the drugs listed here with anticholinergic profile that we discussed. Tricyclics, anticholinergics in general, sedative hypnotics, some antipsychotics, particularly like the olanzapine that we talked about in the previous slide, steroids, and H2 blockers. So H2 blockers you don't want to use in acute delirium because they can make that worse. But if you have a stable patient with dementia and you're using a PPI, which you shouldn't use long term, you can switch it out for an H2 blocker provided the patient is stable. But the rest of them you probably don't want to use in patients with cognitive impairment. For heart failure, obvious drugs like NSAIDs, COX-2 inhibitors are included in that, verapamil, diltiazem, and things like Actos can all contribute to heart failure, exacerbate it, or cause it. So be careful with that. For the 2022 update, dronedarone has been added to the list because it too can be a contributing factor. For urinary incontinence and estrogen, we generally don't use oral or transdermal estrogen for that reason, because there's some lack of efficacy and also increased risk for cancer and thrombosis, and lack of cardiovascular benefit. The 2022 update relates to vaginal estrogen. So it is okay to use vaginal estrogen for recurrent UTI prevention and atrophic vaginitis. They do want providers to talk to patients and have that be a shared decision-making process with a woman discussing the potential risk for breast cancer, because vaginal estrogen is significantly absorbed vaginally. So there may be a risk from that. Next slide. Drugs that should be used with caution. So for aspirin, aspirin is no longer recommended for primary prevention. They have decided that the risk of bleeding outweighs any kind of benefit in anybody over the age of 60. So we can discontinue that aspirin in someone who has not had a primary event. They're revamping the newer anticoagulant guidelines. So Pradaxa is really not recommended in patients over the age of 75 because of increased risk of bleeding. And it's more bleeding even than Coumadin. Xarelto, it's not the first choice medication anymore. It does have a higher risk of bleeding than apixaban or Eliquis. So Eliquis is the preferred agent. But the one caveat is Xarelto is a QD drug. So if there's an adherence issue with the ID dosing of Eliquis, then you can use Xarelto in that instance. All the antidepressants and antipsychotics and tramadol carry the risk of hyponatremia. So I see this quite often in our patients, especially those who are on higher doses of antidepressants or on a cocktail of a little Seroquel, a little mirtazapine, a little tramadol. So remember, tramadol does have a serotonergic component to it, which is why you're also putting the patient at risk for serotonin syndrome, but also it can cause hyponatremia. So just keep an eye on that sodium. Sometimes it dips a little bit, really not enough to do anything about it. But as you increase doses and as you add more drugs that can do the same thing, that the risk increases. And then for Nuedexta, which is a combination between quinidine and dextromethorphan, there's an update from 2022. So the 2019 update stated that you should not be using Nuedexta for behavioral symptoms and dementia, except if there's pseudobulbar affect present. The 2022 update is that it can increase QT prolongation and does increase the risk of falls because it causes a lot of dizziness. So that's something else we have to keep in mind. But again, it should only be used in patients with PBA. Next slide. So there's always a deletion table in every update. They're just deleting some drugs, and most of the ones that they've deleted this time around were due to just non-use. So they looked at Medicare Part D drug usage nationally, and they've deleted all drugs that have been used less than 4,000 times since 2019. If you look at this list, they're pretty old medications. So some first generation antihistamines that have either been removed from the market or just never used. Some CNS meds like barbiturates, hydrogen. I mean, I haven't seen used hydrogen in about 20 years, so I'm not sure. I didn't even know it was still available. And some old cardiovascular drugs like methyl-dopa, reserpine, guanabens. I think if those are still being used, that may be a problem. And then some very old NSAIDs that we haven't used in a very long time, and first generation sulfonylureas, which I'm not sure they're even teaching about in pharmacy or medical schools anymore. Next slide. So there's a drug interaction table on the Beers list. And again, they've updated it, removing some less commonly used drugs like theophylline, phenytoin. It's not that these drugs don't interact, they still do. They're just not used often. And they've removed the Coumadin interaction. In the 2019 update, there was Coumadin on the list. And the reason they did that, they actually do this quite frequently. They decide that if the effect of the drug is not just geriatrics related, and it can happen at any age group, they will remove it from the Beers criteria. So they've removed warfarin for that reason. It's not that warfarin doesn't interact with everything on Earth. It's just that it's not limited to geriatrics. And that's why they removed it. The other update is the addition. So what they want to do is avoid cocktails of centrally acting medications. And so things like opioids, antidepressants, antipsychotics, benzodiazepines, the Z drugs, you really want to avoid these cocktails because they increase the risk of falling. And when opioids are involved, the risk of overdose. They've added skeletal muscle relaxants to that mix. And so what you really want to avoid is combinations of 3 or more. Now, when you're managing pain in patients and you're trying not to use narcotics and you're trying to use these other meds, sometimes you end up on these cocktails. So sometimes it's hard to avoid using a small cocktail of CNS acting medications for pain, but you just have to be aware of the fall risk. And so just keep dosing at doses at a minimum, monitor the patient carefully, and make sure all that's in place. Other things are not new. They've been on the previous iteration. So like this is very common, you start adding medications to the list that all increase potassium. So an ACE or an ARB with potassium sparing diuretics, the potassium is fine. And then they have an infection and you add Bactrim and then you get hyperkalemia. So before you prescribe Bactrim, look at that potassium to make sure it's not going to go above normal with the addition. Again, anticholinergic load, that drug interaction is there. And peripheral alpha blockers and loops increase urinary incontinence in women. These are some examples of the things that are on the Beers list. Next slide. This is a dosing adjustment table. So, it's pretty clear. So these creatinine clearance cutoffs, some are at less than 30, some are at less than 50 or 60. So not a lot of new stuff. They are updating the anticoagulant recommendations. So apixaban is now the preferred agent in CKD. And with the rivaroxaban, they're going to update it based on package insert instructions. So it's just going to mimic that. The rest of it hasn't really been updated since 2019. So for H2 blockers, we want you guys to use them instead of PPIs, but the downside of using H2 blockers is you got to keep an eye on the kidneys. If creatinine clearance falls below 50, you got to do dosing adjustments. It's not that you can't use them, you just have to lower the dose. For gabapentin and pregabalin, I run into this problem quite frequently in clinic. People forget to dose adjust these for kidney function. And gabapentin and pregabalin have pretty generous dosing for renal insufficiency, but you still have to make sure it's under that. And a lot of these drugs, obviously some antibiotics, and then duloxetine and tramadol and triamterene. As kidney function declines, you get more side effects. So there's an increased risk for more side effects with tramadol, duloxetine, hyperkalemia with triamterene, spironolactone, Bactrim, and Cipro has all kinds of side effects associated with it, with reduced kidney function. Next slide. So here's a patient case that I put together, and I'm having trouble seeing the whole thing. Well, let's see how far I can get. So the family presents for a consultation for a medication review, and we originally saw this patient for diabetes. This was a strict diabetes visit. So this is an 86-year-old gentleman with a history of type 2 diabetes for 15 years, hypertension, hyperlipidemia, coronary artery disease with a stent, BPH, insomnia, low mood, mild dementia, and recent onset of incontinence and allergies. AMOCA scores at 20, which indicates some impairment. Family checks blood sugar 2 to 3 times daily. Average blood sugar fasting is in the 150s, postprandial is in 200 to 300s. Families trying to manage diet tightly to the dissatisfaction of the patient. Family feels he doesn't understand the importance of glucose control, which is due to his cognitive impairment. Patient used to be a marathon runner and always kept health a top priority. Prior to the diagnosis of dementia, the A1C values were between 6 and 6.5, and now you can see that they've jumped up to 8.5. So when we're dealing with a demented patient, we always have to kind of look at other disease states and how we're managing them, which is why I thought this case would be appropriate. So let's start with diabetes. So he's on metformin 1,000 twice a day. Amaryl 8 milligrams, which is on the Beers list. It's a longer acting sulfonylurea that can put the patient at risk for hypoglycemia. He's on a maximum dose of Januvia, metoprolol, Flomax, Lipitor, aspirin, donepezil, diphenhydramine, Lomotil, and oxybutynin. So when you look again, going back to the Beers list, you're seeing a pretty significant anticholinergic load. So diphenhydramine absolutely needs to go because it's an anticholinergic medication that can cause more confusion. So Lomotil, again, it has atropine in it, diphenxylate and atropine combination. So it also depends on how often he uses it. So when I see PRN use, I always want to know how often he actually ends up using it. But should not be on Lomotil. And oxybutynin is an anticholinergic urinary antispasmodic, and even at this low dose can contribute to cognitive decline. So looking at the anticholinergic load for this patient by itself, I mean, I wonder if that MoCA is an accurate representation of his MoCA score is an accurate representation of his cognitive function. With 3 anticholinergics on the list, I would want to remove them and retest, right? So I get this question asked often, like if they have incontinence, what are some of the other options for incontinence meds? There are 2 that are very appropriate. One would be Myrbetriq, which is a beta-3 agonist, which does not have an anticholinergic profile. And the other one is Gemtesa, which is a brand new one, which doesn't even increase blood pressure, which sometimes Myrbetriq does. So you can use those instead. So that's addressing the Beers criteria meds. Looking at the diabetes, you know, and some of the labs and vitals that are listed there, we do have to make some dosing adjustments. So with a creatinine of 1.6, I would want to recalculate. I didn't give you a eGFR on this. You would have to recalculate creatinine clearance and see if 1,000 milligrams of metformin twice a day would be an appropriate dose. It may be too high, so we may have to back off to reduce the risk of lactic acidosis. Januvia at 100 is also at max dose, so we may have to readjust that dosing as well. But the main thing with the diabetes, we also have to kind of talk to the family about their expectations. I don't think with this kind of a comorbid situation, I don't think this patient needs to be at a hemoglobin A1C of 6 or 6.5. I think 8.5 is pretty close to the goal for him. Maybe going down to 8 or maybe a little bit less than 7 would be appropriate, but we don't have to be as aggressive with managing it as the patient used to manage himself. So that's a conversation to have with family, to have them relax, kind of look at the diet, see if you can adjust it a little bit and offer healthier alternatives for the patient, but not be so overbearing about blood sugar testing and worrying about every high blood sugar that we get. Looking at recent onset of incontinence and allergies, that really could be directly linked to the donepezil. Donepezil is a cholinergic agent, and its side effects have to do with cholinergic stimulation, which would be diarrhea, so urinary and fecal incontinence, frequency in urination, and runny nose, watery eyes. And sometimes patients take antihistamines for that reason. You know, they have runny eyes, watery nose, or runny nose, watery eyes, and they go ahead and purchase something over the counter like diphenhydramine to deal with that. So that could be directly related to those side effects. So one thing you could try to do is, after you've gotten rid of all anticholinergic meds, back off on the donepezil to 5 and see if some of those symptoms don't improve. Do you guys have any questions?
We have a comment in the chat. Camille has said, is he doing any exercise since he was a marathon runner? Simply walking may help.
Exactly. I mean, and certainly, you know, exercise will help with blood sugar control as well. And so absolutely. Any other questions, comments?
There is a question that was posed earlier. Somebody wrote, wondering about any updates on Ramelteon being added to the Beers list.
From what I saw in the draft, it was not added to the Beers list. We actually use Ramelteon as Remron. We use it occasionally. I mean, Rosarum. We use it occasionally if melatonin is only partially effective. Sometimes we use that. Yeah, it has not been, as far as I know, it has not been added. And they've also not added anything related to cannabis, which is interesting. I think they've stayed away from that issue altogether at this point.
Any suggestions for meds to address pruritic disorders? Most of the agents we've used previously systemically are on Beer's list.
So the one antihistamine that seems to work a little better for itching is Zyrtec, or its metabolite. So you know, that's my go-to first line for that. Sometimes lotions and creams can help with that as well, that are not medicated really. Chamomile lotion can sometimes be helpful as well, but you do want to stay away from things like hydroxyzine and first generation antihistamine.
Thank you. Any other questions for Dr. Gribich? I believe that was our last slide. Let's see.
Yes.
And I think Dr. Gribich just left her email address here. If you have any questions for her, you're more than welcome to email her. Thank you so much, Dr. Gribich. This was a very comprehensive presentation. We will definitely share the slides with you all. And I did share them in the chat, so feel free to just download that, but they will be shared via email, and the recording is usually sent a week or two later. But just for you all, if you do want CME credits, please do make sure that you go ahead and scan this QR code, click this link. That was also sent in the chat, and it will be emailed to you as well. So please go ahead and fill that out. We always also appreciate your evaluations, for our continued quality improvement, and so that we can also plan out our next series. And we love to get recommendations on topics that you want to hear more about. So please go ahead and fill that evaluation out. As an update, we do have quite a few sessions coming up. On March 24th, we have cultural considerations for Vietnamese patients with cognitive impairment. On April 5th, we have safe discharges on how to effectively manage patients through transitions of care. And on the 7th, we have one focusing on caregivers and how to engage and inform caregivers about cognitive impairment. So we hope that you join us in these future sessions. And again, thank you all. We do have a few more minutes if anybody wants to stay on for future questions, but if not, you're more than welcome to leave the meeting. And again, I look forward to that further email that will come to you with all this information. Thank you guys so much.
Thank you.
Thank you all.
So should I stay on for 15 minutes?
No, I mean, I think everybody's leaving, looks like it, but so I think we're good. I'll go ahead and end the meeting. Thank you all so much. And thanks to our hub team for being on today.
Bye.